A warm welcome to all of you joining us for GMF's ongoing programming on transatlantic responses to the coronavirus pandemic. I am delighted that GMF is cooperating with the Embassy of Denmark in bringing you today's installment. We are thrilled to have with us Dr. Søren Brostrøm. Dr. Brostrøm is Director General of the Danish Health Authority, a position he has held since October of 2015. He's had a distinguished career in public health and is a physician by training. He currently represents Denmark at the World Health Organization and chairs the Standing Committee of the WHO Regional Committee for Europe. Dr. Brostrøm, thank you so very much for making the time to educate us about Denmark's approach to this pandemic. Our run of show is as follows. I'm going to give a brief introduction and then turn to Dr. Brostrøm to frame the issue by telling us about how Denmark has been managing this pandemic. I will then moderate a conversation with him, and I will do my very best to weave as many of your questions into the conversation as possible. Please use the question and answer function that Zoom provides, and when you submit your question, just note your name and affiliation. This is an on-the-record session, and we are live streaming on YouTube. You are very welcome and encouraged to join the conversation on Twitter. The hashtag is COVID-19DK. COVID-19DK, of course, for Denmark. So Denmark may be a small country, but it's getting a lot of attention at the moment. I will admit that I opened Sunday's New York Times and I found a full-page article on Denmark by Nicholas Kristof. And you probably can't read it, but the title says, McDonald's workers in Denmark pity us. And the us is us Americans. And then Nick Kristof talks about how he was in Denmark when the pandemic hit. And he writes in the article, the pandemic interrupted my reporting, but I would be safer if I were still in Denmark. It has almost twice as much testing per capita as the United States and fewer than half as many deaths per capita. So with that, let me turn to you, Dr. Brostrøm. Please set the table for our conversation by telling us about the situation in Denmark. What are the lessons you're learning? What are you doing differently from other countries? How is the easing of the lockdown going? And what are you expecting next? So thank you, and over to you.
Thank you very much for that very kind introduction, and thank you very much for inviting me. I really look forward to this. I'm sure I'm going to enjoy the next 50 minutes with you. Just by way of introduction, I am a medical doctor by training, as you said. I worked for almost 20 years in clinical and academic work inside the field of gynecology and obstetrics. So I'm not really an epidemiologist. I'm not really a public health person by background, but I became one after I joined the Danish government almost 9 years ago. And now I have been gradually easing into my current position as a government bureaucrat. And I enjoyed it a lot, though I still long for my clinical work. The current position I'm holding now in my 5th year as the Director General of the Danish Health Authority is a government body. It is the supreme health agency in this country. In the US, you might consider it as a mixture of Surgeon General or CDC director. So we are in charge of not only making government policy, but also executing it in the areas of public health, healthcare planning, quality in healthcare workforce, but also evidence-based guidance, etc. And one of our remits is emergency planning and also managing national health emergency. So in that capacity, of course, the Danish Health Authority became very engaged when we were hit by the COVID-19 pandemic. And for the last 3.5 months, we have been very, very busy managing COVID-19 in this country. So that's my background for speaking to you today. I wish you all a very good morning, all those in the US. This is late afternoon, early summer, a little chilly, but still I chose to sit outside. So I'll just show you around so you can see beautiful Copenhagen here. We are located downtown. You see the beautiful inner harbor of Copenhagen, some nice houses around. And just here you see my offices. So my office is inside here. And I chose to sit outside talking to you so I could enjoy a little bit of the sunshine. So I will just briefly take you through the COVID-19 Danish experience. So early January, beginning of February, our focus was very much containment. As all other countries in the world outside of Asia, we looked at this as an emergent disease developing in Asia and some neighboring Asian countries, and very much with a containment strategy of identifying possible imported cases, isolating and quarantining contacts. So that was our strategy that we pursued also into February. Of course, our whole risk assessment changed when we saw the very rapid development of the epidemic in the north of Italy, in Lombardy and several other regions of north of Italy that developed very rapidly over very few days. And I remember that weekend when suddenly the numbers escalated in Italy. That was a game changer in our perception here in Europe. And we certainly, after that, and that is during the month of February, we saw the development of a new epicenter of the global pandemic of COVID-19. And that was a European epicenter. And after that, Europe quickly took over as the major epicenter of the pandemic. We still pursued containment strategy. We had our first case on the 27th of February. There was an imported case from skiing tourists returning from the north of Italy. And subsequently, we had a number of other imported cases. In early March, we had a reason that we would start to see, and we would probably have, community transmission of COVID-19 in our country. So already the first week of March, more specifically on the 6th of March, we introduced a major strategy shift, and our government introduced the first physical distancing measures. I prefer to use the term physical distancing, not social distancing, because we certainly shouldn't distance ourselves in our social interaction, even though we introduce a physical distance in between ourselves. And that has been one of our sort of major points in managing this. So that was introduced on the 6th of March. I remember that as a very decisive moment for myself, also personally, in my professional experience. I have certainly managed crises. I've certainly managed major health situations. But on the 6th of March, when we had the first press conference, I was standing there next to the National Chief of Police, the Prime Minister of Denmark, and other officials. And we told the Danish population on the 6th of March, from this day onwards, do not shake hands, do not hug, keep your distance to other people of, at that time we said at least 2 meters, that's equivalent to 6 feet. And then we saw almost immediately after that press conference, we saw the population actually acting as we advised them to. And that was really amazing, but that was also a very major step in introducing such major transitions of our social interaction. The subsequent week, around the 12th to 13th of March, our government introduced a number of lockdown measures. And we have had a very decisive government in Denmark in this situation. And what was introduced in the second week of March was closing of schools, closing of public as well as private businesses, closing of cultural institutions, gradual also border control, etc. Also limiting of public transport. And again, a very, very increased communication effort that we spearheaded from the Danish Health Authority in really pushing messages across all channels, social media, print media, public service media, etc., of the key advice to people of keeping distance, keeping hygiene, take care of the vulnerable, etc. And we saw an incredible responsibility in our population. We have also measured it subsequently in seeing what was the compliance and the adherence to the guidance and the regulations from authorities. And it's been impressive. So what we saw already late March and especially early April was that we managed to control our epidemic. On the 1st of April, our curve bent, and since that we've had a downward trend of the number of cases and number of serious cases admitted to hospital, and also the intensive care capacity. We did a major transition of our healthcare system also in the second and third week of March, transitioning into ramping up our surge capacity, especially for intensive care beds. We looked very much at that point in time to the Italian experience. That was very scary. That was basically an experience of a healthcare system that became overburdened, especially with intensive care capacity. So our advantage was that we had a couple of weeks in Denmark to prepare, and we managed actually in a couple of weeks in March to transition our healthcare capacity into a possible not only doubling, but three-doubling of our intensive care capacity. This is on average 450 intensive care beds, but we actually managed to make a surge capacity of 1,200. It's a small country of 5.6 million with a public healthcare system with universal free healthcare coverage, as you know. We never got to use that surge capacity, but I'm very proud that we managed to make that transition. So into April, we saw a drastic effect of the physical distancing measures and the other measures of the lockdown. So already around the time of our Easter holiday, so exactly 1 month after the lockdown was introduced in mid-March, so in mid-April, the gradual reopening of society was introduced by our government in a very decisive manner as well, like the lockdown. So we were one of the European countries that most decisively introduced lockdown, but we're also one of the earliest to introduce the gradual reopening of society. And that was introduced on, I believe, the 14th of April, opening up kindergartens, some school classes, a number of private enterprises, etc. And since that, we have gradually introduced a number of other areas of society. So this week, all retail businesses opened up. This coming Monday, schools, etc., will be opening up again. And we also transitioned our healthcare system back towards, again, admitting patients because we realized we didn't need that surge capacity. So 1 month exactly now, since reopening society, we still have very good control of our epidemic. We were expecting the spread of disease to increase after we reopened a month ago. We have not seen it, fortunately. We still see a very good adherence to the measures that the advice that we have introduced to the people of physical distancing and hygiene, etc. So that is very comforting. So what we are now looking into in the next phase of transition is considering what I would call long-term and sustainable solutions for epidemic control. By sustainable, I mean looking at solutions that will not only last us for a couple of weeks or a couple of months, but possibly also longer, because realizing that very radical lockdown measures of schools and businesses are not sustainable in the long run. A number of other measures of physical distancing, wearing face masks in public, etc., might also not be sustainable in the long run. So we are trying to sort of make a strategy of more focused, sustainable solutions, including now also using a much more fine-tuned system of identifying close contacts, using testing to identify also pre-symptomatic cases of COVID-19 people, and then isolating by using the test strategy instead of a broad-based 2-week quarantining of people who might or might not be infected. We're using the test strategy to actually try and identify pre-symptomatic cases and using that to sustain a more focused isolation strategy. So that is looking ahead. We did have a number of bumps on the road, so not everything was beautiful. And one of the challenges was that, just as many other countries, we had supply issues with personal protective equipment as well as laboratory equipment. So we did run out and had some capacity issues with laboratory testing as well as a PPE. It has since been solved, and we are in a much better situation. So that's sort of my way of introduction. I hope it was not too long. Thank you.
No, thank you. That was fascinating. It's a really impressive story. And I appreciate your also noting that there were some bumps along the road. There are several things that you've commented on that I want to pick up on. Let me start just by focusing on the transition from the lockdown to easing that lockdown. And I want to start with that because it's an issue of hot debate right now in the United States. We're seeing other European countries also starting to ease the lockdown, but I want to drill down on the Danish experience. You may have seen that yesterday, several of our leading public health officials, including Dr. Anthony Fauci, testified in front of a Senate committee. And Dr. Fauci, in his remarks, said, if states or cities or regions, in their attempt, understandably, to get back to some form of normality, disregard the checkpoints that we put in our guidelines about when it is safe to proceed and pulling back on mitigation, I feel if that occurs, you will trigger an outbreak that you might not be able to control. So I want to ask you, what do you think are the most critical guideposts to follow when you're beginning that easing? So here, one of the key factors is we're saying that cases have to have been falling for 14 days before one should start easing the lockdown. But from where you sit, what are the most important criteria we should be following?
Yeah, that's a very good question. First of all, I think you need, as a society, to be in control of your epidemic. I would use that sort of very strong language. You need to know your epidemic. You need to know that you control it, and you also need to have some sense of comfort in your data and your ability to know if you are ahead of your epidemic, and you know what might be slipping for you in your control. So that takes a lot about, of course, being a position where you have data to support your decision and also to support your day-to-day monitoring of not only the epidemic and the numbers of the epidemic, but also of the situation in your society, in your healthcare system, and also as regards to behavior of the population in adherence to the guidance of the authorities. I think we are in a lucky position in countries such as Denmark, which is fairly homogeneous, has a very good and granular data in our healthcare system, and we have an ability to manage our healthcare system nationally that very few countries are in the same position. So the major shift and transitions in our healthcare system that we have managed to do is not for not all countries have that ability, because we have a set of a public healthcare running where we are in a position of planning that very well. We have also been able, from various sources, to monitor testing activity, positive testings, people admitted to hospitals, intensive care use, planning of intensive care use, all that to a very, very granular level of data. So we're not missing a lot, but also data such as day-to-day monitoring of compliance or lack of confidence or confidence in authorities. So these are questionnaires to selected people that will tell us if confidence in the authorities are slipping. And also traffic data is very useful. Traffic data, how many people are crossing the bridges from east to west in our country, for instance? How many people are using public transport? What is the cellular phone usage and mobility of cellular phone users, etc.? All that is giving us a picture of being a little bit ahead of our epidemic and giving us a sense of comfort in our ability to control it. And the second thing is the terminology that we have been using in as you say, lifting lockdown. That is not our preferred terminology. We're not even using the word lockdown in our language. So we are more talking about transitions and of opening or reopening. For instance, our healthcare system never shut down. We just transitioned it. And then we transitioned it back into normalcy. So that is the terminology we'd be using. And we're also talking very much about a gradual and controlled reopening of areas of society. So that's when we open some of the school classes, we talked about a gradual controlled reopening. So not a reopening back into normality, but a reopening with half the class sizes and monitoring that very closely, see what happened to our disease transmission, and then reopening a little bit more, adjusting. For instance, we went down now to saying physical distance of 1 meter, not 2 meters. And then we'll monitor that very carefully before we take the next step. So our government and politicians have also been careful in not opening up too much at a time, then again waiting. And now they have described some phases of a gradual reopening where we are now in phase 2. Phase 3 will be decided politically around the 8th of June. On the condition that we still have the epidemic under control.
So I'm struck by the phrase you started with, that you need to be in control of your epidemic. And then you talked about the power of data in managing this reopening. And I want to ask you, how well do we actually understand this disease we've named COVID-19? It feels in the United States that we started out thinking it primarily attacked the lungs. It now seems that it attacks most of our major organs. We started out thinking that children were largely unaffected. Now we're starting to see this strange inflammatory syndrome that's affecting children. How well do we understand COVID-19?
Yeah, and still day to day, new evidence keep popping up, and we still learn a lot more about it. And I think that certainly also makes a case for why containment strategy was very effective for us back in February, even though we just made a few extra weeks before the epidemic hit us. We probably delayed the epidemic before it hit us in March. And then we have certainly tried to mitigate it so we can control it and then learn increasingly more of our epidemic. I've used the picture of the analogy, if you will, of a wild tiger that sort of jumped on us. We managed to put it very quickly in a cage, and now we are taming it as we learn more about it. And that's sort of how I perceive COVID-19 and the disease. Now we are gradually opening up our society, fine-tuning our mitigation efforts so we can manage to control our epidemic. And what is in the future, I wouldn't know. Will we acquire lasting herd immunity or not? Will we have the possibility of inducing herd immunity through vaccines or not? Certainly a lot of research going on, and I certainly hope for vaccine candidates, but we've been disappointed in the past. Will we have effective pharmaceutical options? Will it be a combination of several things that will manage for us to control the epidemic as we go along? And I think we should look a little bit to the history. This is a new disease. It's a new breed, if you will, of pandemics. Certainly we shouldn't compare it too much to the influenza pandemics, even though a lot of things are similar. But also look back to when we were hit by the HIV pandemic that hit us in the 80s. And I recall that pandemic very well because I was a young medical student as well as a gay person in the 80s. And you have to have lived in that period to know how that hit us. And that was again introducing very major, drastic things in the way we interacted socially. Of course, that was a sexually transmitted disease, and we only had safe sex as the option. We all hoped for the vaccine. Back in the 90s, I remember becoming a young medical doctor and also working with AIDS cases. We were hoping for the vaccine. We never got the vaccine. If you recall, the first pharmaceutical options were not widely available. They were not very effective. They were full of a lot of side effects. And then gradually, we had the combination therapy of new antivirals, less side effects, high success. And then we had also using the options of testing for HIV. So this is a success story, but it took many years or even decades for us to reach that point as regards to HIV. I don't know if it's going to be like that with COVID-19. Honestly, I don't know. Of course, I hope for the big game changers of a vaccine that can be mass produced and we can introduce it. But I think we have to keep our options open and keep a very broad horizons of trying to control it and learn more about it and see how we can manage. And it might be a combination of still physical distancing, hygiene, preventing spread to the vulnerable groups, induced immunity, herd immunity, antivirals, even a combination of everything. I don't know. We shall see.
So one of our watchers wanted to jump in at this point in the conversation and ask you, of the criteria that you've mentioned, you haven't focused on the R number. And this is now, everyone's learning about the reproduction number, and it's become one of the most watched indicators of government success in suppressing outbreaks. And is this an important factor in your analysis? Or help educate us about the importance of the reproduction number of this virus?
Of course it is. It should be for everybody. That's basic epidemiology, and our epidemiologists are certainly very preoccupied with the R not or the R effective. I'm choosing not to include it centrally in my narrative. It's not because I don't believe in epidemiology. On the contrary, it just has to do with my position and my background. That's why also by way of introduction, I'm basically an obstetrician and gynecologist that late in my career merged into public health and government. And that's why I'm sort of trying to promote a somewhat broader focused narrative that is not only focusing on the pure mechanics of epidemics, which I certainly also know that knowledge, and I think it's important, but also a broader public health narrative. And I think that's important for all healthcare people and people involved in healthcare policy in managing this crisis of COVID-19. And from day one in this country, in the Danish Health Authority, we've been very preoccupied with looking at the broader public health perspective of not only mitigating the impact of COVID-19 morbidity and mortality, but also looking at the broader public health perspective. We are very concerned to see a very quick and drastic drop of patients being referred for mental health issues, for symptoms of cancer, etc. People with mental health issues being referred to psychiatric outpatient clinics in this country. We have outpatient psychiatry, mental health services free of charge for everybody. It dropped by 60% within a week after lockdown being introduced. That is very concerning. We saw the same number of things happening. We saw a concerning drop in the number of patients being referred for invasive cardiac procedures. So that was when we said, okay, look, we have to manage this as a public health crisis, not only the COVID-19, but also the broader scope of effects. So we focused very early on also on mental health issues as regards to not only the COVID-19 and but also the impact of the lockdown measures.
Super. And we've got several questions that get to some of the specific aspects of reopening society. For example, one of our viewers is interested in how you went about reopening schools. And I'm sure several people saw some of the articles about you're using a soccer stadium in Copenhagen for school so that you could have appropriate physical distancing. But they're asking what your advice is for other countries as they think about how they might be able to bring students back to schools.
Sure, that's a very good question. So we were a little bit first movers in this country because we chose to open not only schools but also kindergartens as one of the first areas of reopening. Many other countries chose different areas of society, perhaps from the reasoning that schools and kindergarten would be difficult. And it certainly was difficult because of a lot of uncertainty, a lot of emotions, of course, regarding your kids and etc. So we went about it in a very sort of safe way, perhaps too safe. So our safeguards being introduced was we doubled the requirements for how many square meters a classroom should be and how many kids could be in a classroom per square meter. So only half class sizes, reduced school days, physical distancing between school kids in class of 2 meters, a lot of hygiene requirements for hand washing and sterilizing of toys in kindergartens, etc. And that sort of met two different groups. One group of parents, and that was very active on the social media, saying you're using our kids as guinea pigs in testing this reopening of society, which was certainly not our intention, but it was perceived as that. What was the explanation of why you choose kindergartens and schools as the first area to open up? On the other hand, you had another group of parents saying that when it's about time that you opened up kindergartens and schools. We need our kids to go back to school, but why do they have to wash hands all day and they can only be with half of their friends in class? So opposing positions that became a little bit difficult for us to manage and also explain our guidelines. And now we are easing up on that in opening up schools, and we certainly gained a lot of experiences in that. We try to engage stakeholders, parents, educators, trade unions, etc. We certainly, looking back, I would have engaged them even more and earlier on to sort of have ownership of what we did. So that would be my advice to other countries considering opening up schools.
It's an interesting point that you make about including as many stakeholders as possible. And several folks have focused on the fact that the trust that citizens have in their government can be very important as one is seeking to manage a pandemic. And one of the questions that has come in relates to the politics of fighting a pandemic. And this person is noting that in the United States, we're in a political year because we have a presidential election this November, and the issue of fighting COVID-19 has become quite political here in the US. And we do use the term lockdown here. So we've seen anti-lockdown protests in various state capitals. We've seen protesters denouncing stay-at-home orders, calling for the restoration of freedom. Are you seeing any of this sort of polarization in Denmark, or have you been able to keep the response to the pandemic unpolitical?
No, it is certainly political in this country, as in most countries, and I think it should be political. In the first couple of weeks of the measures being introduced in March, there was very, very sort of national unanimity about the measures being introduced, but that sort of quickly evaporated into politics as usual. And we are an open democracy with a very active population in political discussions, and that certainly then became political. But I think it should be. I'm not disappointed that it became political. On the other hand, I was expecting it, and now it's certainly becoming a very, very political arena, being discussed among the political parties in parliament about what areas of society should be opened up and why, and what are the conditions, and all the questions that you are asking is certainly being asked in the public domain in this country, in media and discussions. And it should be, and I think we have a lively democracy. It is not as polarized as I see it, for instance, in the US. But our politics is not that polarized either. I think what you need to realize with a country like Denmark is that we are in general a society of high confidence among citizens, but also high confidence in authority. And we know that from also other areas of life. So in general, Danish people would have high confidence, for instance, in the government, knowing lots of stuff about you. So Danish people are generally not that concerned about public health officials or government offices knowing all kinds of data being stored about you, as opposed to some other countries that are more hesitant towards that, and generally a high confidence and trust also in the messages from the authorities like the Danish Health Authority. But it's not a blind confidence. So Danish people like their freedom, and they certainly like their freedom of information and their freedom to debate. So if the authorities disappoint them, then they would be very quick in criticizing. And that is a challenge that we have seen here, of especially when it regards to compliance and adherence to our advice, physical distancing measures, etc. We basically have two drivers of the compliance. So these are the 3 C's. The two drivers of compliance in authority messages is, on one hand, concern, and on the other hand, confidence. Concern about the epidemic, about the disease, about society, about the state of the world, about the economic crisis hitting us, about your own situation, your own family, your employment, being unemployed, etc. So that concern is one driver. The other driver of compliance in authority messaging is the trust and confidence in your authorities. And what we can see is increasing confidence is when authorities, in a broad sense, authorities are clear and concerted in their messaging. We see confidence in authorities slipping when it's unconcerted. And by authorities, I mean in a broad aspect, not just our Danish Health Authority, but also the politicians, all the professional authorities. So when we have mixed messages, as we have had in this country around testing strategy, to make one case of a very messy sort of public discussion, then there's a lack of trust in the people. Then say, okay, they should get their acts together between the Danish Health Authority and the Medical Association, this professor, that professor, and the politicians. So that is sort of what we are trying to manage in an open society with critical media. So that is sort of the issue. So what I did also personally is I tried to engage in as many, or not only me, but also other parts of the Danish Health Authority, try to engage in as much in public discourse as possible. So we've certainly been keeping very busy in speaking to media, participating in media discussions, but also engaging with various public health and public stakeholders. Thank you.
Super, thanks. Let me ask you what kind of preparations you're making for a possible second wave. Now, my understanding is that as you are reopening Danish society, there's an expectation that you might see spikes in certain places. And then it sounds from what you said before, that your expectation is that testing and contact tracing would allow you to get that under control. And I saw a quote recently from your state epidemiologist, Cora Molbach, saying that he thinks Denmark is very unlikely to be hit by a second wave of the virus because of those plans for testing and contact tracing. So help us understand how you're thinking about that second wave. Do you expect it? Do you really think you can control and prevent it?
Yeah, that's going a little bit back to the narrative of we feel that we are fairly confident in our ability to manage and control the epidemic, also going forward with gradual reopening of society. So rather than speaking of a second wave, I would rather say we will continue to monitor and manage our epidemic. And I believe we have a good monitoring of our epidemic and various other indicators as discussed initially. So we'll be able to reintroduce measures of control if needed. So rather say it like that, rather than sort of sitting and just doing nothing and waiting for a second wave to hit us. That's sort of not our strategy. And in that strategy, I see the sun is setting a little bit behind the houses. Yeah, I'm sorry. But in that strategy, we're also talking very much about sustainable solutions for managing transmission of disease. By sustainable, I mean introducing measures that is also implementable on the long run without too much regulation.
And actually, one of our viewers was interested in drawing you out on exactly what you mean by sustainability. And let me just add a question to that, which is, you're right that what you just said gets back to your earlier point about you need to be in control of your epidemic. What does that mean for travel restrictions? Because you mentioned at the very beginning that the first cases in Denmark were imported cases. I know that you still have travel restrictions in place, but how can you control your epidemic if people are coming in from other places and may be importers of the virus?
Yeah, that is certainly a discussion that we'll have moving forward. It's not really a major discussion at the moment because there's not a lot of international travel going on. I mean, we have a major hub here in Copenhagen, a major international airport. I believe they have like 5 or 6 arrivals every day, and most of them are domestic. So we don't really have the big issue. But of course, I mean, pretty soon the discussion is going to be about international travel and tourism, and certainly I see that going on across Europe. There is discussions, I think, inside the European Union. Of course, the EU has open borders. Now there are border controls also inside the EU, European Union. But of course, having open borders, it's an obvious discussion for the European Union to see how can that be developed. So I'm expecting to see that discussion sort of moving forward. And also that is sort of, it's a two-way thing because it needs to be discussed between countries also of how you want to make that travel. So that's a little bit broad scope, probably not answering your question completely, but we're not that far in the discussion yet.
But it's a great point because you do have to talk with your neighbors, with other Europeans in managing this. And of course, Denmark is not an island. You're almost an island, but you have very close neighbors in Germany and Sweden. You're a member of the European Union. Give us a sense of what that regional cooperation has been like. We've seen a country like Italy be very critical of European solidarity, saying they felt very much abandoned when they were in the deepest, darkest hours of the crisis in Italy. What is your experience of regional cooperation within Europe?
No, we've certainly tried to do it, and especially also we had many discussions and collaborations inside the Nordic countries. But it is obvious that the Europe has not been totally concerted in our approach to managing the COVID-19 epidemic. That is very obvious. Even just looking to our closest neighboring countries of Denmark, Sweden, Norway, and Germany, you basically see 4 very different approaches to how you manage the COVID-19 epidemic. There's been a lot of discussion in this country as regards to what Sweden has been doing, because they have pursued a very different strategy, where I think that we have compared ourselves and exchanged ideas much more with Norway. So Norway and Denmark has in many senses pursued the same strategies. That's certainly, I mean, looking back, it could, from a European perspective of European cooperation, you certainly could have wanted for a more collaborative or concerted approach across Europe to managing the epidemic. But that is not the case, so that's more a historical point. It will certainly give us a lot of very, very interesting evidence on what worked and what did not work. So I think for researchers and epidemiologists, it's really good that you've had different approaches. Now I think we are approaching each other gradually. So in our sort of gradual reopening and transition into more sustainable solutions, Sweden going a little bit from a different perspective, but certainly more or less merging into perhaps the same situation eventually. So the discussion will more be about how did you approach it in the first couple of months, but will probably end in the same more sustainable approach to managing epidemics, I think.
That's interesting. I'd like to draw you out a little bit more on the differences of approach, maybe among Denmark, Germany, and Sweden. I think the contrast with Sweden is quite clear, and many have looked at Sweden as the outlier in terms of the approach Sweden has taken. The Swedish argument would be that they would be well served in the longer term because you're seeing much higher exposure to the virus and therefore much higher immunity levels. It'd be really interesting to hear your take on this whole question of exposure and immunity and what that means going forward. So if you could speak a little bit to the comparison with Sweden, but then also help us understand how your approach is different from the German approach.
Yeah, I'll be more comfortable speaking about what we did in Denmark, because I very early on decided I would not sit in judgment of what other countries are doing. That's been very popular by a lot of commentators, etc. But I don't think it's really the point. But I certainly should explain and also, in a sense, defend what we did in Denmark. I'm very happy looking back that we managed to control our epidemic early on. I mean, it's a matter of history if lockdown measures were too much or whatever. But the timing was right, and we managed to get control of our epidemic. We managed to transition our healthcare system, especially with ramping up intensive care capacity. We didn't manage to ramp up PPE and laboratory capacity in exactly the same successful manner, but we did transition our healthcare system into managing an epidemic, and now we have it under control. So in that sense, I was very happy about that, and I'm very happy that we did avoid the situation that, for instance, we've seen in Italy and also in other countries across Europe of overburdened intensive care units. We managed to avoid that, and I'm fairly confident that we'll not get there. So in that sense, I'm happy about our approach, and also the way that we managed to make our transitions back and forth as rapidly as we did. And even though it's also been politicized and sometimes messy in this country, I think we still have a fairly good and high level of confidence. So in that sense, yeah, I think that's a comment I would have. I don't want to sit in judgment of what our countries are doing.
And you obviously, based on your role in the World Health Organization, have some important insights into how we are trying to manage this pandemic globally. There's been real concern that the pandemic and the spread of COVID-19 in the global south could be devastating for many countries that have poorly developed public health systems, fragile economies. There is a question that we have from one of our viewers about the recent influx of asylum seekers into Denmark and how that's affected Denmark's response to the pandemic. Could you speak a little bit to those global aspects of the pandemic and the impact they'll have on your response or are having?
Sure, certainly. And I think I mean, it's a pandemic. Of course, we need to manage this globally, and we should. I still have a grave concern of the possible effects of the pandemic in areas of the world with much weaker societies and much weaker healthcare systems. That is certainly a concern, still a grave concern. The epicenter started in Asia, China and some other Asian countries, and they managed to control their epidemics. It moved with the new epicenter to Europe. We had our issues, and not everything has been beautiful in Europe, but still we managed to control our epidemics. And even in the Southern European countries, Italy, France, and Spain, that have been hit very hard, they are also managing it now. You've certainly had your issues in the US when you became the third epicenter, especially New York City and other areas. You seem to also be able to managing. But I have a grave concern of, for instance, a major epidemic evolving in the Indian subcontinent in one of the major African countries with major populated cities. So that's still a global concern. I would applaud the WHO for very early on initiating and facilitating research and sharing of knowledge in the area also of developing vaccines, etc. Because globally, in managing this pandemic, this is what we need to advance. We need to have, for instance, vaccines, if possible, is certainly going to be a way of controlling this pandemic.
We've had a question from one of our viewers about the multitude of treatments that are being discussed in various countries, from chloroquine hydroxide to Metasphere and other things. Do you see effective treatments out there?
I'm following the research and the science as well as the next guy. So I'm not a pharmacologist or an expert in that. So I'll make a more broad comment in saying that I think we are very fortunate to have a lot of clinical studies being developed very rapidly, and also of having regulatory bodies being very active in sort of facilitating advice and rapid improvements of clinical studies, etc. Remdesivir is a very good example of a study that was being set up and implemented across countries in a multi-center way, evolving very rapidly, where you can recruit many patients very quickly, and you can very quickly get well-designed, well-powered studies that will answer the questions that we need to get answered very quickly. Is there a drug out there with safety and efficacy that we can use? That is extremely important to get that very quickly and to get it out very quickly. And I think the next thing we need to get is studies of combination pharmacology, for instance, combination antivirals, etc. Again, looking back to what worked in other areas, just HIV, hepatitis C are good examples of how antivirals actually were the game changers. And then we certainly need to have the vaccine. I think that the WHO has listed more than 100 groups studying possible vaccine candidates that need to be narrowed down, of course, to what can be used in clinical studies and what can be eventually mass produced. So we need certainly the research, and we need governments to step in to support that research.
So on the vaccine, as you know, there's a race to develop the vaccine. It seems that there are some who are very optimistic and think you might have a vaccine by the end of this year. Other people are saying, look, typically it takes at least 10 years to develop a vaccine. Maybe the shortest could be 18 to 24 months, but don't forget, then you have to distribute the vaccine and you have to inoculate the majority of your citizens. As you plan forward in the Danish government, what is your planning on a vaccine? When do you think it is most realistic that a vaccine would be available to the majority of Danish citizens?
I don't have a qualified response to that. I think other people can answer that better than me, but we certainly want to be in there in eventually participating in clinical studies and also sort of being very much ahead in also possibly procuring the vaccine and implementing it in our strategy. That's for sure. I don't want to be the expert on what are the possibilities of having vaccine candidates. I think we should certainly, just going back to what I said was important in the pharmacological studies, I think we need to have a very good system also across countries in how we facilitate rapid clinical studies of possible vaccine candidates, because it's extremely effective. We have the experiences from other epidemics and pandemics. I'm thinking about the SARS, Ebola in West Africa, vaccine candidates being developed, and also the Zika virus experience. I think we are gradually learning how to develop and test and regulate vaccines quicker and quicker, but it does take time. We also need to realize that you have to have an epidemic evolving to do the clinical studies. You have to have a certain number of people being exposed. So you might even say, as a dilemma, that if we are very effective in controlling our epidemics, it will be difficult to conduct large-scale or well-powered clinical studies, because you need to have some exposed people. And that is certainly what happened, I believe, with the Zika virus vaccine, because the immunity developed in Latin America, etc. We sort of the Zika epidemic went away by itself, and so we didn't have the exposure to have the power of the clinical studies to test the vaccines.
So let me ask you, how does this end? I mean, you've talked a couple of times about the need for long-term sustainable solutions. Is your view that testing and contact tracing can be that long-term sustainable solution? Or when you talk about a long-term sustainable solution, ultimately, does that mean a vaccine?
No, I think it's a multifaceted approach. And that was the point I was trying to make previously with the narrative. I don't think there's one quick fix, one superpower weapon. Not, at least not that I know of now. It might come in the form of an antiviral or a vaccine or whatever. So we need to have a multifaceted, multi-layered, multi-dimensional approach. A more focused contract tracing, testing, isolation strategy is certainly one pillar of our sustainable strategy going forward. The other pillar is still very much a focus on hygiene, using hand disinfecting, cleaning contact surfaces, using contactless solutions in our society, etc. The third is very much still a focus on physical distancing and trying to sort of implement that in more sustainable ways in our society. So I think we have to be very careful of not trying to boil down the success of epidemic control to one game changer, or the hope, to instill the hope in one thing. The vaccine will come and everything will be good. Because then I'm afraid that we might be slipping and losing in other measures that are equally important.
Well, I think that's a terrific message to end on. And I will say the sun is literally setting on you.
It is. I'm sorry. Yeah.
We do need to bring this fascinating conversation to an end. Dr. Brostrøm, it was such a privilege to be able to have this conversation with you. I certainly am wiser for it. I appreciate your time, and I also really appreciate a message that came throughout your narrative, which is also the importance of international cooperation.
Sure.
In context, whether that's across the Atlantic or whether it's globally. And certainly that is a mission that my organization is very much committed to, and we are thankful to you for your efforts in this pandemic. So thank you. A final thanks to the Embassy of Denmark, which has been a terrific partner to us in bringing this event about. We wish you the very, very best in your important work in Denmark.
Thank you very much. I really enjoyed it. I enjoyed talking to you. I hope I can welcome you all in Copenhagen when the world opens up again, and please come and visit beautiful Copenhagen.
Well, now that we've all seen your balcony, we're coming.
Sure.
Thank you so much. Stay healthy.
Yeah. Bye-bye.
Bye-bye. And thanks to all our viewers. Bye-bye.